Presentation. So my name is Allison, and I am a third-year PhD student in the Bioengineering Department on the CU Anschutz campus. And I study acute lung injuries and ventilator-induced lung injuries, which we will talk ad nauseum about in this presentation. And specifically, I am looking at a potential drug to treat these sorts of conditions, and it is an anti-inflammatory drug. So next slide, please, Duncan. Awesome. So first, I just want to talk to you guys a little bit about the basics of the lung before we dive too much in. So on the left-hand side here, I have a figure of a person, and it shows their upper airways, which starts in your head, and then you go down the throat, and this is your trachea. It starts to bifurcate into your bronchi, into your right and left lung. And as your lungs go down, we have these branching structures that are ducts, and they end in these little kind of grape sacky looking things called alveoli. A single alveoli is called an alveolus. And the function of your lung is to conduct gas exchange, so to oxygenate your tissues and to take carbon dioxide away. And the functional unit of your lung that actually participates in that gas exchange is called the alveolus. And what it is it's this little membranous sac that's lined with liquid, and it inflates, and it gives oxygen into the bloodstream, and it takes carbon dioxide out of the bloodstream. And the way that you actually generate the pressure for breathing is done by your diaphragm. So your diaphragm changes the pressure in your chest cavity, which allows your lungs to expand for inhalation and to kind of compress for exhalation. Next slide, please. So acute lung injury, we abbreviate this as ALI or ALI, and there's lots of different ways that you can get an acute lung injury. So the most common cause is bacterial sepsis. This accounts for about 40% of acute lung injuries. And basically what that means is that the patient has a really bad bacterial infection that starts to lead to lung injury. Now, increasingly, COVID-19 is also a reason that people get acute lung injuries, and it's similar to the bacterial sepsis where there's just a lot of inflammation happening. Another interesting one would be gastric contents aspiration. So what that means is when someone is laying on their back and they vomit and then they inhale that vomit, the acid and the food contents can cause lung injury. And similar to that, there are inhalation injuries. So this is if you inhale something that you just really shouldn't, like bleach. Then there's pneumonia, which is a syndrome where the lungs start to fill up with fluid. And then lastly, there's severe trauma. So if you got hit in the chest really hard, or if you got a car accident and it got a chest injury, that can also cause acute lung injury. Next slide, please. So when acute lung injury gets really bad, you get something called acute respiratory distress syndrome, and we abbreviate that as ARDS. So on the left here, I have this image of a healthy patient and an ARDS patient having a chest x-ray. And you can see in the healthy person, you can really like delineate their lungs. They're nice and black. You can see right through them. And the reason for that is because they're filled with air, and x-rays penetrate through air very easily. However, in the ARDS patient, you can see that their lungs are really like cloudy, and it's hard to really differentiate exactly where they are. And this is because they're filled with fluid, they're filled with inflammatory cells. There's kind of all this junk in the way that is not letting there be just nice, clean air inside. And so people who have ARDS typically have a lot of inflammation, and they also have something called increased pulmonary vascular permeability or edema. And this just means that their blood vessels are leaky and that there is basically fluid flowing into the lungs from your blood vessels. They also have increased lung elastance, which we will talk more about later, and increased dead space. So a normal person has dead space in their trachea and in their conducting airways because there is air in these places in the lung, but those aren't where gas exchange is happening. Gas exchange only happens in the alveoli. So people who have ARDS, a lot less of their alveoli are functioning, so they have more dead space, so more parts of their lung that aren't participating in this exchange of oxygen and carbon dioxide. What this leads to is something called hypoxemia, and that just means that the body doesn't have enough oxygen in it. And unfortunately, what this typically leads to is multi-organ failure. Next slide, please. So what do we do to treat ARDS? Well, when someone is in ARDS, that means that they're in respiratory failure, and that means that it's impossible for them to breathe without the help of a mechanical ventilator. So without being placed on a machine that does breathing for them, they will not be able to exchange oxygen enough to be compatible with life. Now, the next slide, please. And so before I talk more about mechanical ventilation, there's just a couple of little terms that I'd like to talk to you guys about. So the first one is positive end expiratory pressure, and this is abbreviated PEEP. And what it is it's the pressure that is generated by the amount of air in your lungs at the end of your exhale. I think the best way to describe this is kind of with like a little personal experiment. So if you take a nice deep breath in, then you breathe out, you'll notice that you can breathe out a little more. You can still breathe out a little more. You can still breathe out a little more. Now, the amount of air that's left at the end of your exhales, that is the PEEP. And you can't really breathe out all of the air in your lungs. You can't get to a PEEP of atmospheric oxygen, because what this would mean is that all of your alveoli are collapsed. Your body won't let you do that. Next slide, please. And so in terms of talking about this, there's lots of different lung volumes that we have. So if you were to take in the biggest possible breath, that top volume there is your total lung capacity. That's the total amount of air that your lungs could possibly have in them. And when we're breathing normally and quietly, we're never breathing out all of our air and then breathing in our total lung capacity. What we're breathing is in a range called the tidal volume. So this is, you've got a fair amount of air in your lungs, you breathe in, you still could breathe in quite a lot, and you breathe out. And this is just like nice, quiet breathing. And some important values here just are this total lung capacity. We also call this inspiratory capacity, and this is just how much air your lungs can possibly hold. And then the expiratory reserve volume is basically that amount that you can push out, and the residual volume would be what's left that your lungs will always have inside of them without some sort of machine intervening. The next slide, please. And I hope that you can play this video, and if you could just play it kind of a couple of times. What these are a slice of lung tissue, and all these little balls in there are alveoli, and this is just normal breathing. You'll see that even at the end of the exhale, when they're smaller, they're all still inflated, they're all still little balls, they stretch a little bit and then they come back down. They stretch a little bit and they come back down. However, oh no. Okay, this is this kind of same setup of the alveoli that are breathing in and out, except for this lung has been damaged with oleic acid. And what you can see here is that the alveoli, some of them are still open, but many of them are collapsing entirely at the end of the exhale. So you can't really see them anymore. And similarly, when we injure the lungs with something called tween, which is a soap, you see the similar pattern where they're collapsing entirely at the end of the exhale, and then they're kind of opening back up and collapsing entirely. And this is something that's really injurious for your lungs. It's not good for your alveoli to collapse. And kind of to drive home this message a little bit more, we have this image here of an injured lung that's going to be inflated. And what's happening here is these kind of white areas are already inflated. They're pushing in air, a little bit more of the lung can get inflated, but there's still all these stubborn sections that are really, their alveoli are collapsed, and they're driving in more and more pressure to be able to pop open these areas. This is pretty injurious for the lung because the areas that are already open are now being subjected to much higher pressures than they really should be. So when you have lung that has lots of collapsed regions, it's quite hard to ventilate it properly because you don't want to be overstretching the regions that can be opened, but then you also want to open up as much as possible to facilitate the most gas exchange as possible. So that leads me to talking about something called ventilator-induced lung injury, or VILI. And like I mentioned before, mechanical ventilation, you need it to be able to save an ARDS patient. It's necessary and it's a life-saving intervention. However, VILI can occur, and what this is it is an exacerbation of your existing lung injury or a generation of new lung injury just based on the way that we have to ventilate people to be able to give them enough oxygen to maintain life. And this contributes to the really high ARDS mortality rate, which is about 40%. So currently the standard of care that doctors will use is something called the ARDS-NET protocol. And what it dictates is that you use a high positive end expiratory pressure, that PEEP. So they keep a good amount of air in the lungs at the end of every exhale so that the alveoli have less of a chance to collapse. And then they also use small tidal volume. So just a little bit of air in, a little bit of air out, between 6 and 8 milliliters of air per kilogram of the body weight of the patient. And what this is trying to do is reduce that overdistension of lung tissue that already is open. But unfortunately, even with these methods, VILI does still occur. And so we think that there's a pharmacological intervention that is needed to try and stop this process. So the rationale behind this is something called the cytokine storm. And basically what this is that acute lung injuries, they will start to generate some inflammation because your immune system wants to fix whatever is wrong. Unfortunately, this kind of can lead to like this positive feedback loop where you have these pro-inflammatory markers that are calling other things to increase the amount of inflammation, which call other things to increase inflammation. You just get this big inflammatory mess. And this is kind of a pictographic representation of the storm that happens there. And one of the key players in this storm is TNF alpha. And this is a cytokine that activates a lot of different things like IL-6, IL-1 beta, and IL-2. And so what we want to do is we want to break this feedback loop of inflammation. So the way that we are doing that is with a nanoparticle drug called CNP-MIR146A. And it's basically comprised of two things. It has these CNP nanoparticles, which are mostly a delivery vehicle for the microRNA. They do also reduce inflammation, but I'm not going to get into that in this talk. But what is decorated all over the surface of these nanoparticles is a microRNA that's called MIR146A. In lots of different studies, they've shown that this is kind of a molecular brake to inflammation. And the way that it works is it stops the expression of TNF alpha. And so if there isn't TNF alpha, then there is one of the key players that activates other pro-inflammatory cytokines. So that helps to reduce overall inflammation. And so the way that we test this in our animals is that we have three groups. So we take mice and we split them into three different groups. One of them are control mice, and they are just given saline. And then our injured mice, we give them something called lipopolysaccharide, which basically just elicits a really big inflammatory response in their lungs. And then our treatment group are mice that are injured with this lipopolysaccharide and then treated with this drug. And so we have a couple of metrics that we use to assess like what their lung function is looking like after these injuries and treatments. And so like I mentioned, this inspiratory capacity, so how much air can go in and out of the lungs. And then another big one is elastance. And this is kind of a metric of how floppy or stiff the lungs are. And I think a good way to think about this is like a balloon. So if you have a balloon that's really thin walled and you blow into it and it blows up really easily, you know, you don't have to put in that much air or pressure and it gets nice and big, that would be something that has a low elastance. And that's typically how your lungs are when they're healthy. However, if you think of one of those balloons that like a balloon artist uses to make those animals, if you've ever tried to blow one of those up, they're really hard to blow up. So those are ones that have stiff elastance. They have really high elastance. And as the lungs get more and more injured and progress into ARDS, the stiffer they get and the harder it is to put air in them. It requires more pressure. So I just have a little bit of experimental data to show you guys here. So this is the inspiratory capacity. These blue dots that are closed are saline mice. So these are control mice and their inspiratory capacities. And then this is their inspiratory capacity after 3 hours of mechanical ventilation. And you can see they're healthy. Their inspiratory capacities don't change over the course of mechanical ventilation. Now we have these LPS injured mice, the lipopolysaccharide injured mice. You can see that before ventilation, they have quite a reduced inspiratory capacity compared to the controls. And then it gets worse when you mechanically ventilate them. So after 3 hours of ventilation, it gets even lower. And these green triangles here, these are the mice that are injured and then treated with the drug. And you can see that they are not statistically different from the control mice before or after mechanical ventilation. So that makes us happy. And then when we look at their elastance, we kind of see a similar trend. So the control mice have an elastance around 26 before mechanical ventilation, and it doesn't change with mechanical ventilation. The LPS injured mice, they're stiffer before mechanical ventilation. They're kind of around 30, and then afterwards they get even worse, get up to almost 40. Now with the treated mice, they have similar elastance to the control mice starting, and they just get a little bit worse over the course of mechanical ventilation. So we can tell pretty significantly that this drug is reducing the amount of injury in these mice, and it's also protecting them from getting more injury with mechanical ventilation. And with that, I'd like to thank you guys for your attention. And if you have any questions, I'd be happy to answer them.